Hello, I'm Dr. Wanda Torres, MD. I am the founder of Suncoast Women's Care, a medical facility renowned for our expertise in women's reproductive health, obstetrics, minimally invasive surgery, and robotic assisted surgery. Join me each week as I interview guests in the top of their fields about the world of OBGYN, exploring the innovations and personal stories that shape our medical experiences. Hello, everyone. I'm Dr. Wanda Torres from Suncoast Women's Care, and today's guest is Dr. Ariana Tiberi. Welcome, Dr. Tiberi,
Thank you.
to our
Thank you.
conversations with the physicians. So today's topic is a topic that we talk about every single day, and is hysterectomies. There's a lot of misnomers with the hysterectomies, and patients get confused on what type of hysterectomy they have. So tell us a little bit about what is the difference between a complete hysterectomy, a total hysterectomy, and a partial hysterectomy.
Yeah, I definitely agree that a lot of patients, especially if they've had their hysterectomy, many years ago, they're unsure. They just know where the scars are. They're not really sure, what kind of hysterectomy was done. But we have total hysterectomy, which is otherwise known as complete, or more commonly known as total hysterectomy. And then we have a subtotal hysterectomy, which is what a lot of patients call partial hysterectomy. So the difference between them is essentially a hysterectomy by itself involves the removal of the uterus with the fallopian tubes, which are attached, inherently to the uterus. The difference between a total and a subtotal is the fact that the cervix is removed in a total hysterectomy.
hmm So then, of course, we also call it a supracervical hysterectomy. So the patients that have had a total hysterectomy versus a supracervical hysterectomy, how do we follow those patients in the office? Do we need to do pap smears?
Right. So that's the big benefit of a total hysterectomy. So when a total hysterectomy is done, the cervix is removed. If the reason for the hysterectomy had nothing to do with the fact that they had abnormal pap smears, then no, we do not continue, in clinic, we don't continue screening for cervical cancer. Obviously, there will be no more uterus, no more cervix, and no more fallopian tubes. The removal of the ovaries is something that's discussed kind of case by case, but also age dependent, and the reason for the hysterectomy.
Okay. So for patients with supracervical hysterectomies, we continue doing pap smear following the recommended guidelines. So depending on the patient's history, etc., we will discuss in the office how often they need to have the pap smears.
Exactly.
So then we do offer different types of hysterectomies, right? So we have from vaginal hysterectomies to abdominal to laparoscopic assisted or robotic hysterectomies. So how do we counsel our patients for that?
Right. So it depends, a lot of it is really based on why we're doing the hysterectomy. There are a lot of patient specific factors that come into the decision making. So, like you mentioned, we have vaginal hysterectomies, which are the surgery is performed completely through the vagina. Then there's abdominal approach, which means the incisions are on the belly. The uterus is, the surgery is performed through the belly. That can be a large incision or a laparotomy. It can be done through tiny incisions in a minimally invasive fashion, and that could be laparoscopic, meaning we go through tiny holes with sticks that we're controlling with our hands at the bedside, or we're going with a robotic assisted approach where we still have the sticks that are going in through tiny holes and keyhole incisions in your belly, but we're operating the sticks through a robot, which has finer ability to have finer movements and kind of more precise surgical techniques.
Okay. So when I discuss with the patients the approach of the vaginal hysterectomy, I tend to offer this to the patients that have prolapse, uterine prolapse. And of course, you have to make sure that the patient follows the recommendations and directions after the during the post-op period. So how do you counsel these patients for the vag hyst and the prolapse?
Right. So, vaginal hysterectomy, like you said, one of the indications could be, prolapse of your organs. We want to make sure the patient doesn't have too many prior surgeries on the belly that can complicate a vaginal hysterectomy. We want to make sure that on exam we have enough space to operate and do our surgery. As far as the post-op period, of all hysterectomies, the important thing is avoiding any heavy lifting for usually up to 8 weeks. And we also advise them not to have anything go in the vagina for 8 weeks as well, including intercourse, douching. No, not that we ever recommend that, but
Mhm.
those are kind of the important post-op recommendations. As far as hysterectomy go, the recovery after a vaginal hysterectomy is the easiest of all the forms of hysterectomy. You will have, typically 2 weeks of downtime, but most of the time you go home same day. You're walking around, minimal pain. Typically Motrin, Tylenol is what they would need.
So, can you tell our patients about the ERAS protocol and how do they manage this in post-op?
Right. So ERAS stands for, extended recovery after surgery. It is a relatively new introduction to the surgical world, and the point of it is that we get faster recovery after surgery. Typically, a lot of patients, some of them still think that once you have surgery, you need to rest, stay in bed after that, and that's typically the older generations. But for now, the main recommendations after surgery is to get up as quick as possible. That's part of ERAS, not to stay in bed, to ambulate as much as possible to prevent things like clots in the legs,
Mhm.
clots moving to the lungs. We want minimal use of narcotic medication, which is a
That's
big
very
one.
important.
Not only for the epidemic of narcotic abuse and disorders that we have going on in this country, but also because narcotics can affect the way that our body heals. It slows down our intestinal function, and as we're doing more and more of these hysterectomies in a minimally invasive fashion, it does require putting gas in our belly, which we'll talk about. But it does require kind of inflating the belly, and that can kind of irritate the bowels as well. And so the most prominent pain after these type of surgeries is actually gas pain. And
Mm.
so minimizing how much narcotics are used for pain can also contribute to faster recovery.
Okay.
And then the other thing that's kind of a pillar of the ERAS protocol is resuming normal diet and normal function after a major surgery.
So I just want to bring up because part of this ERS protocol that we use is just giving the famous drink to the patients, and they find it interesting because we have told them to be NPO, nothing to eat or drink, and then we require for them to drink this 2 hours prior to the surgery. So, can you just tell the patients a little bit about this?
Right. So the idea about behind that is kind of a carb loading picture.
Mhm.
So 2 hours before, it's a liquid drink that's full of essentially sugar, and it raises their blood sugar, and it kind of also allows for stimulation of cortisol and appropriate response to surgery and healing.
Right. Perfect. And it helps also, the gastric motility and the intestinal motility to come back faster after the surgery. For our hysterectomy patients that are either having an abdominal hysterectomy or laparoscopic robotic assisted, we also offer the tap block. So, can you tell them a little bit about this and what do we use it for?
Right. So tap block is a transabdominal plane, basically an injection of local anesthetic that's done prior to the surgery, and it's usually performed by members of anesthesia team. Using an ultrasound, they'll go on the patient's belly and they inject a needle into the muscles of the belly. What this allows for is prolonged postoperative pain control and management by having that long-acting, basically a form of lidocaine into the muscle.
Mhm. So again, going back to a faster recovery and the patients resuming normal activities faster after the surgery. So anything else that we want to discuss about hysterectomies?
So yeah, we can touch on, the major differences most common hysterectomies perform nowadays. As much as we still wish we were doing a lot of vaginal hysterectomies, we are tending to, move away from vaginal hysterectomies for mostly because of, I would say, an increase in the pathology and the burden of pathology, the numbers of surgeries, the higher order C-sections that patients have had, prior to needing or requiring a hysterectomy. Um, so typically we do, for the most part, perform hysterectomy via a minimally invasive approach, no matter the pathology size and depending on, surgeon experience. We do it through those tiny keyhole incisions, like we were discussing, which doesn't require, inflating the belly with gas. Otherwise, we wouldn't be able to see. Everything would be just collapsed on itself. They tend to be quicker procedures, easier recovery, and less post-op pain as opposed to a bigger incision. Anytime we do those type of surgeries, there's always risks involved, like just like any surgery and how we would discuss in clinic, before going ahead with the surgery. But any type of minimally invasive surgery always has the risk that we may need to, in order to safely complete the surgery, we may have to open, a bigger cut on the belly. Usually, typically in the in the same way C-section is done.
But those, I want to emphasize that those risks are minimal. When you look into studies, the highest risk would be around the 4%. So I always tell my patients, let's look at it in reverse. 96, 99% of the time, everything goes according to plan without any issues or risk or complications of surgery.
Exactly.
Thank you, Dr. Tiberi.
Oh, thank you so much for having me. It was a pleasure.